Okay, it is 12 o'clock, and I think we're going to go ahead and get started. I want to welcome everyone to this public health seminar, Understanding Social Determinants of Health from the Ground Up, Taking Neighborhood Health to Heart. I am Cerise Hunt. I'm here with the School of Public Health, and I'm just so excited to have members of the Taking Neighborhood Health Heart here to present today. And I'm going to just take a moment. We're going to have a little panel discussion. And our first panelist is going to be George Ware. George is a graduate of the Ohio State University. After receiving his MS in preventive medicine, he moved to Colorado Springs, where he was the disease control manager at Fort Carson. He recently retired from the Colorado Department of Public Health and Environment, where he worked in the STI HIV section and more recently supervised an evaluation unit. He is a co-chair of the Taking Neighborhood Health to Heart and lives in the East Montclair, one of the Taking Neighborhood Health to Heart's 5 partner neighborhoods. Patty Iwasaki. Patty is a co-chair of Data Review and Dissemination, a committee of Taking Neighborhood Health to Heart. She has worked in community-based participatory research for 8 years in Colorado and along the U.S.-Mexico border, with a focus on health equity, health disparities among communities of color. Patty serves as a Minority Health Advisory Commissioner until 2013. She is a social worker with research training in community health and social program administration. And then Debbie Main, and she's a professor and chair, Department of Health and Behavioral Sciences, University of Colorado, Denver, Taking Neighborhood Health to Heart. So I want you all to just take a moment and just help me welcome our speakers as they come forward today.
Now let me see if I can get this right. Good, I can do it. Welcome. Thank you for coming today. And I just want to tell you what we're going to go over. We're going to talk about the social determinants of health and how that's related to the projects that we're doing in our 5 partner neighborhoods. And we want to make sure that everybody's on the same page. So Patty's going to be going over community-based participatory research. And then we'll actually look at some of the data that we got from the study that we did and some of the challenges and opportunities related to doing community-based participatory research, especially as we've experienced those in Taking Neighborhood Health to Heart. And hopefully we'll leave enough time to have some discussion and questions. Okay. And one of the things that I was reflecting on when I was getting ready for this talk was that there's actually been an evolution of how we look at health disparities, how we look at health equity, and the evolution has been essentially from talking about health disparities to talking more about health equity. And just as a review, in terms of health disparities, back in 1999, the National Institutes of Health had defined it as differences in the occurrence of new and old cases of disease, deaths, and the burdens of disease and other conditions as they affect specific populations in the United States. And that contrast, just some example of some of those health disparities, some of the ones that especially are that I've worked with over in my career in public health have been those in HIV and gonorrhea. And you can see where African Americans and Latinos experience the higher rates of STIs compared to the rest of Coloradans. And as the same holds true with tuberculosis. But I don't want, and what we oftentimes see is that when people hear about health disparities, we always start thinking about how these impact people of color or people of different ethnicities, and we forget that there are disparities that also occur in terms of income, where you saw in 2007 that people who made $15,000 a year or less were more likely to report physical limitations as opposed to those who had incomes greater than $50,000 annually. And then another example is sexual orientation, where you see that almost half of the people who are living with HIV in this country now are men who have sex with men. And so again, I just want to bring that to people's attention so that we're not thinking that we're just talking about racial and ethnic disparities. One of the things that I was reflecting on in preparing this was that for the longest time, working for the health department for 20-some years, we always used to talk about health disparities, and we talked about those disparities, but we didn't connect the dots. We didn't talk about how oftentimes these disparities were unfair, and they were avoidable differences. It was sort of like, well, that's just the way they are. Those examples I gave you of the high rates among African Americans and Latinos compared to the rest of Colorado. We never said anything about what this idea that it was fair or that we could avoid some of these things. And that's why when I started looking at some of the literature where it looked at, who was at the forefront of looking at actual inequities, you don't really see that much in this country. You do now, but especially back in 1999, you didn't hear that much about it. It's only more recently that we've begun talking about that in the United States. And I started thinking of, why is that the case? Why don't we talk about that more? And there were a number of things that went through my head, and we could probably spend the rest of this hour talking about what some of those things are. But some of the things that came to mind for me was the fact that there's that American narrative about pulling yourself up by your own bootstraps, that one can rise above one's original station in this country. And also there's a real reluctance to talk about the legacy of slavery, of how we dispossess people in this country, and other forms of discrimination that have resulted in some people benefiting more than others in this country. And I think that reluctance leads to the fact that we don't talk about health inequities. And so when you start talking about health inequities, where are they coming from? And I love what the World Health Organization Commission on Social Determinants, what they had to say about that. That those health inequities reflect an unequal distribution of power, income, and goods and services. And this results in people experiencing different outcomes. And that one of the things that was striking about this is that it's not natural. I mean, that you come to the place where you're saying these things happening are not natural. And I reflected upon that in terms of my career and how for the longest time I even accepted that, you would say that, poor people are going to have worse health outcomes as opposed to those who are more affluent. And I start questioning, why am I accepting that? And I no longer do anymore. There's no reason why, if you don't have a good income in this country, that you have to experience poor health outcomes. And again, that's I think my blindness. And when I look at some of the things that are happening more internationally, it makes me rethink that and say we need to challenge some of the assumptions that we make of who is going to be in good health and how those things come about. And it's especially striking that they say that these things result from poor programs, social policies, unfair economic arrangements, and bad politics. And we're in the midst of a national election, and we need to be reflecting on what that may look like, what kind of conversations that we're having, what's the role of government, what's our relationship to one another. And I think that I'm excited in the fact that we're having this discussion today because it suggests new roles for public health also. Okay. And so in terms of the social determinants of health, all that is the circumstances in which people are born, grow up, live, work, and age, and the systems put in place to deal with illness. And again, those are shaped by other forces, economics, social policies, and politics. And when we start thinking about those circumstances, we start talking about things like the availability of affordable foods, mothers receiving prenatal care, whether you're living in a neighborhood that has sidewalks that are well lit, that has parks, access to good schools, whether people have social connections, whether in their neighborhood or in the places where they work, whether there's affordable health care, whether there's transportation that's available to people, Do people have access to well-paying jobs? Are they experiencing racism, stigma, other forms of discrimination? And we start looking, it also suggests that we need to look more on policies. I come from a background, we were always talking about interventions, and more lately in terms of interventions that were what I call out-of-the-box interventions. They were models that were used that oftentimes they dealt with the individual rather than dealing with a community as a whole, and they didn't look at a wider context of what influences behavior. And what I'm encouraged about is there's opportunities for new directions in terms of looking at policies. And anymore, I came to the conclusion that there is no policy that's implemented anymore that does not involve health. And so the things when we're talking about our war on drugs result in more people of color getting arrested and incarcerated than people who aren't of color, and that reflects on people's their neighborhoods, their ability to take care of their children. We look on recently in the legislature, they were talking about enterprise zones, where they encourages businesses to go into areas that need development. Well, we've been looking at where grocery stores are sited, and you sometimes wonder, why are there new grocery stores being put in some of these neighborhoods when the neighborhoods that we are in, oftentimes they don't even have one good store, let alone multiple stores. And so you're thinking, can't we use those policies to inform where these grocery stores are? And finally, we'll hear again and again in the literature about gays and lesbians being wanting to be married. That has health implications. I don't think that there's any policy that cannot be framed in terms of health. And we need to be at the table and start connecting the dots for people if we're really serious about addressing health inequities. Okay, wait a minute. Oops. And so I didn't want to just talk about inequities. I wanted to give people an idea of what equity would look like. And a few years ago, Whitehead and Dahlgren had suggested that ideally everyone could attain their full health potential, and no one should be disadvantaged from achieving this potential because of their social position or other socially determined circumstance. And I'm thinking that'll give us somewhere to move to, sorry about that, rather than something to move away from. And let's see. Oops. And so one of the things that the World Health Organization Commission on Social Determinants of Health, what they had said, some of the principles that they have proposed of action to achieve health equity is that we pay attention to the conditions of daily life. We improve those conditions. We tackle the inequitable distribution of power, money, and resources, and we start measuring the problem, evaluating our actions, expanding the knowledge base, and developing a workforce that's trained in the social determinants of health, and that we raise the public awareness about the social determinants of health. One of the things that I think our group does, taking neighborhood health to heart, and especially the community-based participatory research approach, is engaging community in these, in addressing these principles. It's really tempting to say we address those principles, but we address them from the ivory tower, or we address them from the state health department office. But you cannot do these things well unless you have, in terms of sharing power, in terms of being able to interpret what do these data mean, and to say what directions that we should go in. Those are the things that I think community-based participatory research does a great job of engaging community in looking at, well, how are we going to do those things? And I would assert that if we don't engage community in saying which directions that we're going in, then despite the fact that we talk about social determinants of health, we really won't have change anything from the old way where we didn't necessarily focus on health equity or the social determinants of health. And I think I might run over a little bit, but I'll turn it over to Patty now.
Any of you who know us know that to keep the three of us, between Debbie, George, and myself, in a very concise manner is a struggle. So I'm going to just stick to my notes. Community-based participatory research is a form of research that has been practiced since the late 90s. And this description or definition is taken from an Agency for Healthcare Review article on community-based participatory research. And it states CBPR is a collaborative research approach that is designed to ensure and establish structures for participation by communities affected by the issue being studied, representatives of organizations and researchers in all aspects of the research process to improve health and well-being through taking action, including social change. I like using this quote from Paulo Freire because he is largely credited as being one of the theoretical anchors, and I would also add that the theory base of community-based participatory research has yet to be really flushed out, and we hope that we contribute to some of that in our work and as a article production that we're looking at. To have faith in people, to believe in the possibility that they can create and change things. Liberation begins to the extent that men and women, and that's my insertion, reflect on themselves and their conditions in the world in which and with which they find themselves, to the extent that they are more consciencial, and forgive me for anyone who speaks Portuguese here, they will insert themselves as subjects into their own history. I'm going to go through several points that have been outlined by Barb Israel and Minkler in the course of many of their articles on community-based participatory research. Not all community-based work is participatory, and not all participatory work is culturally proficient. And so doing community-based participatory research is not expedient, it's not fast. It recognizes community as a unit of identity. It builds on the strengths and resources of people in the communities. It facilitates collaborative, equitable partnerships in all phases of research. And I want to stress all phases of research, including translation and dissemination back to the community that you serve or that you do work in. And it involves an empowering process. It promotes co-learning and capacity building. And again, I want to stress, capacity building is not standardly what research does. And in that sense, in promoting capacity building, it strikes out a very core that distinguishes ourselves from standard research, and that is we believe in power sharing, and we believe in making that playing field more equitable. It integrates knowledge generation and intervention for the mutual benefit of all partners. It emphasizes local relevance of public health problems and multiple determinants of health and disease. It builds on problems identified by the community, not necessarily solely by a researcher, but by the community saying that this is something that they would really like to see being studied. And often verified by other data sources. Its process is cyclical and iterative. The research goals may not always be known at the beginning of work. And Debbie, who will talk about the case example of taking neighborhood health to heart, can bring out some of those examples. It disseminates findings and knowledge gained to all partners and individuals engaged, and their input is included in the dissemination process. In short, I just want to emphasize, it is participatory. It is a collaborative effort between academic and community partners. It promotes co-learning and capacity building. It is aimed at systems development, and in that way, it is often very much change-oriented. It is empowerment-oriented. In other words, if you aren't bringing along community folks and developing skills and capacity of that community, you are not being thoroughgoing in your work doing CBPR. And it is localized engagement with a long-term investment. And this, okay, now the technology test. Okay. This chart by strand shows the difference between traditional research and CBPR. And the goal of research for traditional research is to advance knowledge. But in CBPR, it is the betterment of the community, and it's the betterment of lifestyles or the way of life for that community that you're working with. The source of the research question in traditional research may come from theoretical work, but with CBPR, it's community identified. The designer of research, the trained researcher in traditional research, but the trained researcher and community in CBPR. And I'm going to just stress on this, the role of the researcher and community are both as collaborators and both as learners. The relationship of the researcher to participants. In traditional research, it's very common, and we started our work with 5 neighborhoods asking people, how many of you have participated in research? And a lot of people raised their hand, and we said, and how many have gotten those people who did the research go back into the community and work with you on whatever was the results? And there was silence. And we said, well, we're hoping to change that. And again, Debbie will give some examples of how that has come about. The value of research. In traditional research, it is the production of publications, it's presentations at conferences. But in CBPR, there it is. The value of research is what it does contribute not only to community change, but to that element of capacity development. And again, we will talk a little bit more about that. The owners of the data in traditional research, it is the academic researcher. In the community and in CBPR, it is the community, and that's why we have a data review and dissemination committee and have had since the beginning. And then the means of dissemination, as I said, in traditional research, it's academic conferences and journals. And in CBPR, it's any and all forums, media. It could be a rec center meeting and the results of rec center development. It could be going to planning meetings for a grocery store in the neighborhood. It could be engaging with others to make sure that there are transportation, which we like to use as an example in terms of this campus. But I'm going to stick to my time and let Debbie take over from here. Oh. Okay, I think I'm going to... Everybody hear me? Oh, that's off. Okay. All right. Well, in this third segment of our presentation, what we wanted to do is kind of take social determinants, CBPR, and pull it all together in a living example of kind of how we pulled this off and continue to pull this off after 6 years. Today, in fact, how we think about ourselves, and we're actually, it's sort of hard to pigeonhole us, but one of the things that we think we do pretty well is to really spend time, a lot of time, collecting, making sense of, and disseminating what we call local level health data. And what I'm going to do is I'm going to walk you through our story talk about some of our processes, and again, hopefully keep bringing you back to the fact that we keep coming back to social determinants, living conditions, and other things when we think about how to understand and improve the health of our 5 neighborhoods. So the premise, in fact, and I'll just tell you our premise going in, and then hopefully by the end of the talk you'll be convinced that of our premise. First of all, our premise is by enhancing confidentiality, trust, and relevance of community-based health information, again, in our case, local level, it's best addressed early and in an ongoing, meaningful way. Okay, so we start out in the beginning. We continue to engage with one another. Community members, as I'll show you in a bit, have been involved from the very beginning of this project. And by spending the upfront time, there are big payoffs in terms of getting really helpful input on the content of how we collect our data, how we make sense of our data and interpret our findings over time. We get the word out in terms of sharing information with the people affected within these neighborhoods by these issues. And then we spend a lot of time talking about what's next. Given what we know, given what we have, what are we going to do next in terms of collecting additional data, sharing it with other people who will actually be involved in policy, environmental change, intervention development. It doesn't make sense to me. I should go to the right. I keep thinking forward is right. But so here's how we started. We began in 2006 through an NIH-funded grant. We actually applied for, it was an RFA called Community Participation in Research. And I actually think that context is important because really the nice thing about that funding was they knew that part of what we do is we were just beginning. So we actually got funded to spend time together, number one, engage. So our goals were engage a diverse group of people within 5 very different neighborhoods, which I'll show you. We collected a lot of what are kind of critical data on the health of people as well as the neighborhoods. So we didn't just spend time looking at individual level data, but really what do communities look like in terms of their look and feel. And then finally, the third goal was to make sense of the data, get the word out, and really use the data on behalf of community. Originally, the focus of the study on the research side was the impact of the built and social environment on health and health disparities. And as you'll see, it continues to be the case, again, because community input, what people cared about was really the conditions within which they live, play, work, et cetera. And that actually fits with that research focus. Oops. So when we started, East Montclair, these are our neighborhoods, and our partners, University of Colorado Denver, as well as Anschutz Medical Campus. Stapleton Foundation was pretty pivotal in helping us begin to get in the neighborhoods and get involved with these 5 groups. Again, East Montclair, Northwest Aurora, Northeast Park Hill, and Stapleton. And this is actually our footprint, our beautiful map that has evolved slightly over time. But, and as you can see, Peoria, we're very close to this campus. So it just abuts Peoria. Thing to pay attention to is, and I think this is one of the remarkable things about the project, is look at the very real differences across our neighborhoods. So this isn't, and when Patty sort of defined community, in this case, we're talking about 5 very different neighborhoods who share an interest in kind of neighborhood health and kind of working together to make improvements across all neighborhoods, not just within one. So again, you look at differences in reduced free lunch, education, percent in poverty, quite a range. And I think that's what makes this project pretty magical in a lot of ways. So how did we start? So first of all, we worked with Stapleton Foundation and people within the 5 neighborhoods and began to just have early discussions about what mattered. So unlike other projects where you come in and say, here's what we're going to do, and here's the protocol we're going to follow, and I hope you guys will sort of participate when you can, we started from the very beginning and said, what matters to you? What are some of the health things you worry about in your neighborhoods? And then based on initial focus groups, we then pulled together groups of people and at one point into a council, and anywhere we've had anywhere from 20-some to 65 people show up in our meetings. We have upwards of 100 to 200 people who participated throughout the years. So anyway, we started by asking, then we started forming committees and actually doing the work.
one of the things, and this is actually the mission statement that was developed by the community group, and I'll just read the mission: to provide space and opportunity for people to share, support, grow, and realize common visions for healthy neighborhoods and find solutions to the challenges. And again, this is below. You just notice it's, we come from all walks of life. We are people who live in neighborhoods, people who care about the neighborhoods, et cetera. So a very, very diverse group of people in so many ways. So in terms of data collection, again, when Patty talked about CBPR, George talked about social determinants of health, very early on, we worked together to begin to sort of brainstorm and collect data. In the early years, we first did a household survey of 950 adults. We collected a lot of information on what the neighborhoods look like. I mean, literally, we collected data within households, and we literally walked streets around the households to say, what's lighting, sidewalks, canopies, is it covered by trees, are there bushes in the way so it feels scary? Alleys, one of the things that our community members really early on while we were designing these things, they said, we need to look at alleys. A lot happens in alleys, good and bad. We need to be auditing alleys, and we added that. So I'll talk a little bit later about how community has really impacted the project. But across everything I mentioned, it really has been influenced, conducted, et cetera, by people who live in these neighborhoods. So we did a number of interviews, and then later we actually collected more data in apartments. We looked at grocery stores, the price, quality, and availability of fresh fruits and vegetables. I'll show you a little bit more. I'll show you a summary of those data later. But a lot of data collection. I mean, this project really was, let's work together, let's collect data, and let's make sense of it and do something with the information. Oh, you can't, I don't know if you can see this very well. I can't from back here, but the point is, if you think about the definition that George talked about in terms of social determinants of health, very few, if you look at the individual level, whoa, I don't know what it's doing. But anyway, if you look over here on this corner, lots of individual health measures of how much activity, what people eat, et cetera. But so much of what we collected is in these other parts of this matrix: food resources, safety, schools, in terms of lots of things around the schools, resources in schools. We collected data on community health centers and whether they take insurance, things like that. So we, through the course of this project, have collected a lot of data that really reflects the social determinants of health, and not just whether people have access to care, how much they walk, whether they're obese, et cetera. So we look at the living conditions within which people live and work. The other thing, and you notice this, and I'll talk briefly about this, but community has added a number of things about what it's like to live in these places in terms of racism, discrimination. Again, I talked about the alleys and what's it like to walk around my neighborhood. Can I go dip back in my alleys? So again, those data are reflected in our footprint in terms of what we've collected. Love this graph. It's really to reflect the fact that there are so many things that happen in terms of where you live. And our goal is to begin to tell the story when it makes sense to people about all these different living conditions, and that really reflects all the data that we collect. So how has community influenced the focus? Well, first of all, the focus originally when Debbie worked with a few people to write the proposal was, I thought, boy, it would be really neat to really look at the impact of having a new redevelopment called Stapleton on the surrounding neighborhoods. Oh my gosh, within a meeting, people said, well, that's interesting, but I want you to spend more time understanding my neighborhood. I don't care quite as much about this new redevelopment. I need you to understand my neighborhood. So within second meeting, we changed it to understanding the health of people in all neighborhoods, not just relative to Stapleton. The other thing is the whole inequity focus, and like I said, collecting data on social conditions, environmental conditions, economic conditions was a big deal to people. And again, built social, cultural differences within and across neighborhoods was a big focus of the project, and continues to be so. Okay, methods is where it gets really interesting. I mean, early on in this project, I had a colleague of mine say, what are you doing? Community don't care about data. They don't care about methods. And it couldn't be more different than that in this project. from the very beginning, community members helped design the surveys. They were very clear. In fact, originally we proposed using a very similar method to the health department with the behavioral risk factor surveillance system, where there would be cold calls, right? Cold calls from people. People would answer the phone, answer some questions, and our community members said, "Are you kidding me?" First of all, a lot of us don't have landlines. Second of all, our cell phone numbers keep changing, and so what we think you should do. And third of all, somebody looks on their caller ID and it says University of Colorado. Are they going to pick up and answer a survey? Everybody's shaking their heads no. Well, that's what they're saying. Are you kidding me? And so they actually proposed a two-stage recruitment process where community members were hired and trained to go door to door and recruit, collect some information from people, and then they got called over the phone, so a telephone interview. So two-stage system of data collection. Again, if you look at, I don't have it here, but we actually have a paper, I think, that's online, and I think Cerise has copies of, or maybe you sent them out. Anyway, if you look at the people we were able to contact with this method, we look very different from some of the usual methods in that we reached a diverse group of people. Our data look very different from like Denver BRFSS data. Anyway, so I think community had it exactly right then in trying to think about better ways of working with people who live in these places. Household survey, again, I talked about, they added questions on perceptions of neighborhoods. So community was really clear. They want to know about how people feel about some of the assets in their neighborhoods. Not just what's wrong with us, but what are some things that we really like about our neighborhoods. Again, added more data on the built environment. And then later on, we actually collected data on other things based on what we were seeing, for example, grocery stores, and we also looked at parks. Let's see. So the other thing I'll talk about is communities really shaped how we make sense of and get the word out about our data. So I have like 3 examples here. I'm going to go through really quickly because we want to take time for discussion. But in addition to individual data, some of the things that actually were probably among the most powerful for community were maps about patterns. So this is an example of a map where we actually took the question, over the past 12 months, did your household ever run out of money to buy food? One of the things that we did early on in our getting the word out is we actually visited different groups and presented some of this information. And I have to say, this one map, and actually a couple other maps around food and how often people actually eat fresh fruits and vegetables, was eye-opening for so many communities. In fact, I remember us presenting at Northeast Park Hill in their meeting, and this slide alone, people said, what is going on? How do we have people who run out of money for food? We need to do something about this. So between sort of typical graphs of data and patterns of data, fairly quickly we designed a study to look at what's going on in the local food system, and we actually audited grocery stores on price and a number of things. So again, looking at patterns and not just individual data where you see a graph on percentages of people who ran out of food really had an impact in terms of conversations. Here's what resulted in the early conversations. People wanted to know sort of where they could buy food, and what's even more interesting about this graph, and I'm not sure how much you can see, but red is not good. So if you think about each of these graphs, it's the percentage of 22 in every store. We went into every store and looked at how many of 22 fruits and vegetables they actually had in a store. And you don't see a lot of green on this map. So the typical methods are, where are the stores? And often when you do food systems work, you just audit what's there, and people say, oh, there's not a food desert here. We see lots of stores. But if you actually go inside to these stores and look at, and I don't have the price, I have a really interesting map on price and the variability of price. But this alone, when you talk about having access to fruits and vegetables, this shows you that there isn't easy access in these neighborhoods. A couple places with some exceptions. Here's the final one where this is an interesting map in that it looks at open space, rec centers, things like where after school programs are going on. And again, when you think about equitable conditions, there are very big differences across neighborhoods in terms of parks, rec centers. In fact, one of our Taking Neighborhood Health to Heart steering committee members, Mark Burry, actually used information from our survey to really argue for better amenities in rec centers within Northwest Aurora. And if you look at original Northwest Aurora, right here, you can see that there are some things, but there aren't very many, and in other places there are more. So anyway, he used some data to argue for, and actually they got more resources for one of the rec centers in Aurora. Critical piece of this, and I think that sort of relates to Mark using the data, but also a number of our both community-based organizations within our neighborhoods using data, or different us using data for grant proposals and other things. But I think data ownership, and when you look back and think back to even slides around sharing power, building capacity, all of that, owning and sharing data is one of the key components. So one of the things that happened very early on, before we finished collecting data, was actually Patty and a couple other people raised the issue. We really need to talk about how we use data, understand history in terms of data misuse, and come together and design a plan for how we're going to do this very differently going forward. And that's when the Data Review and Dissemination Committee was formed. 8 to 10, and in fact, probably more than that. And, we have monthly meetings and a range of people show up. But really the key piece of this is early on, again, before data were analyzed, we put together principles of how we're going to do this work together. Like when people want to use data, what has to happen. We actually put together, actually made a commitment that before data go out into a peer-reviewed publication, data are disseminated to all the neighborhoods. So we did a series of things to get the word out about the data. So the key is data are shared first with the community. And then we spent nearly a year just really trying to make sense of data, figuring out the best way to report data, things like that. So one of the things about, in terms of principles, is all projects requesting data must, there are things like, how are the data going to be used? Will the data benefit a community? That seems like a really obvious thing, but often that's not the case. And so really the process for reviewing when people can use data relates to that. How are data going to be reported? I know early on, we actually were very sensitive to the fact that we don't want to continue to use data to say, oh, this is a good neighbor, this is a bad neighborhood, this is a bad neighborhood. Oh, look how different Stapleton is from everybody else. And so we were really clear that we wanted to sort of, early on, we sort of blinded the neighborhoods, so we didn't have neighborhood names on things. And again, I think we still tend to do that, because often our point isn't comparing neighborhoods, but if you start looking at some of the social conditions, income, a number of things, that's where some of the really powerful patterns come up. And it's not just one neighborhood or another. And then, again, I think we really are clear that we don't want to sort of focus on the let's blame people, and you show the data and say, oh, well, this neighborhood is really different, and that's why this happens. And so we just wanted to change the conversation around this and really focus on conditions and resources and things like that, and not just people. So lots of accomplishments with data review, and I'll finish this, I promise, in 2 minutes. First of all, we spent over a year interpreting, and we have a number of dissemination materials. So you can't really, the point isn't to read these, but to know that we actually created 5 very different health briefs on 5 different, so chronic health conditions, physical activity, nutrition, healthcare access, a number of social conditions of neighborhoods, and created, again, with community designing this, kind of briefs that go out across neighborhoods. We have Spanish and English versions. We also have a summary form, again, just so that people can take one sheet and summarize what things look like in each neighborhood compared to all neighborhoods. Again, not saying neighborhood 1, 2, 3, 4, 5. Continue to use that. One of the big accomplishments, too, was when we began to look at our data, we noticed that people were missing. So even though we did, I think, a great job of using the 2-phase recruitment, we couldn't get into locked apartment buildings. We realized that there were really important populations that we weren't getting at with our original study. And again, part of what community, they're like, somebody's missing, let's figure out how to get funding to fill it in. And so the DRAD actually was funded through CCTSI along with 2040 Partners for Health to actually disseminate findings, collect data in apartments. I love this idea, though. They actually came up with what's called house meetings. And so the typical way of getting the word out is you have always this similar people always going to community meetings, and you miss really important people who don't go to meetings. I mean, I don't know about how many people go to your community meetings, but I think it's a different group. And so we were trying to get really creative about how do we get the word out. So we actually had people in our communities hold house meetings in their neighborhoods. They facilitated, the grant helped provide food for a meal, talk about issues, and there were a number of over 25 house meetings with 200 and some people where that was one way to figure out how to involve people in taking neighborhood health to heart and talk about what matters to people. So just quickly, data have been used in a number of ways to go in front of city council, for grant proposals. Again, we shared data. In fact, with 2040 Partners for Health, they were interested in discrimination in healthcare, so we could quickly sort of pull data and share that, on behalf of the communities. So this group could tackle that really important issue. We have food subcommittees, a number of things as a result of having these rich data. I actually think it's you guys going through quickly challenges. So I will turn that off. Yeah.
Okay. Some of the things that we come up with in terms of the challenges, and these are only a few, and they are actually, anytime you have a challenge, you can turn that into an opportunity too. But certainly, when you start looking at social determinants of health, they're really a lot broader than we've tended to frame health issues in the past. And so certainly, getting away from looking at this more stovepipe way of approaching an issue, that's somewhat challenging for people. And so when you're talking about doing CPPR, making sure that you take a more holistic approach, not saying, I'm just going to talk about diabetes today, I'm just going to talk about HIV today. That doesn't work. In community, people bring their whole community to the fore, and especially when you get a lot of different people who are talking about their issues. And then also there's that long-term commitment that you have to make. A lot of times when you get, I think about how funding came in through the state health department, and a lot of times it's like, okay, let's wrap this up in 3 years and move on. You can't do that. You've got to commit to long-term being there. And actually, Patty had talked about that iterative process of you're going to find out things that you go in there. We originally it was talking about the built environment. We've gone well past the built environment now. We're taking neighborhood health to heart. You've also got to be very thoughtful about what structures, what processes, what relationships are you going to create to keep this partnership going. And that's a challenge, and that's something that you don't know going in. We've had a lot of discussion about, okay, what's important to people when they have those meetings every month. And one of the things that people said was, okay, make sure you leave time to talk about community announcements, what's going on in our community. And I don't think we would have thought about that before. It's more that people said, this is what's on our agenda. So we make our process fit the people the communities that we're working with. And there's tools that people are going to use and capacity building. And I would say that actually the capacity building and the tools, sometimes it's more the research people who need it. I'm grateful that Debbie and Patty were very open to becoming and to listening to us. But it's also many times researchers don't come from these neighborhoods, and they haven't experienced some of these things. And so especially in terms of cultural competence, you've got to provide people with that. You've got to be thoughtful about that. And so, and on the flip side of that, the capacity building, many community people may not have been as conversant in things like sample size and what's going to be a level of evidence that's going to be critical to supporting some of the things that we're going to propose. But I would say, actually, surprisingly, many people picked up on that pretty early in community, and they were asking questions like, well, how do we know that's a valid finding? And it's like, okay. And finally, in terms of identifying and engaging the right people, community-based participatory research is all about action. And if you're getting as broad as we're getting, if you're looking at as holistically as we want to look, you're going to have to look for new partners. We're challenged to say, okay, taking neighborhood health to heart, that anywhere from 50 people who may take part in a monthly meeting, we may not have the right tools, we might not have the right people. I would even suggest that some of the people who haven't been involved that we do need to get involved are historians. There's a story behind these neighborhoods that we need to know about. And that's what I mean by the right partners in schools, in transportation. I don't want to just talk to people who are in traditional public health, because I know that we are challenged to reach policymakers. We want to make sure that we're talking to our legislators, that we're talking to our city planners, and that's what I mean by new partners. And especially when I think of institutionalizing this model, one of the right now, when I reflect on this, a lot that it can be very personality driven. A few people. I am so grateful for Patty, for Debbie, for their commitment. But we need to make sure that it's not just about a few individuals, that we always have people who are coming to the table, that the university has a way to connect with this work, that there's not just people like me too who maybe have worked with the health department, but we need to make sure that that this model, this way of doing work, that we can make sure that this continues.
I just wanted to, sorry. I always figure I talk loud enough. In this room, there are a number of people who are here that have worked with Taking Neighborhood Health to Heart, or are members. Could you raise your hand, Steve and Catherine and Charlene and Michelle? And of these folks that are here, many of them had started as recruiters and are now working in the research area. I want to acknowledge Charlene because in the very beginning, it was not a magical process. We really had to work with folks. And so we hammered out over, I would say, at least a 6-month time period, operating agreements. And Charlene and Gwen at that time met with every single person who participated in a focus group to see if they were interested and willing and committed to having a process ongoing beyond the focus groups. Because I just want to demystify, it's not like you have focus groups and then assume that everybody's down for having some kind of organizational buy-in. It is not an easy, expedient process. And I want to acknowledge Charlene because getting together with folks when they're at work or off of work or on their weekends or whatnot took a lot of investment, and it was a very time-consuming process that the organization became gelled. But I want to make sure that we do have time for your questions and whatnot, so I'm just going to stop there. Any questions?
Yes.
We're facing one of the worst epidemics ever in our obesity epidemic in the United States. A lot of the things that you've mentioned bordered on things that would really influence that, and I appreciate the multiple variables that you looked at. But do we have a plan for any outcome measures that can say, vis-a-vis at least this terrible epidemic, has there been a measurable outcome? Do we have any evidence? Do we have anything that's evidence-based to say this helps?
Good question.
I think you actually hit one of our challenges on the head, in that originally our goal was to begin to collect data early on, and then a number of things start happening related to policy with food, bringing in different stores, improving sidewalks. Where George lives, he doesn't have a sidewalk. Are there things we could do to make it easier for people to get out and walk, related to obesity and other things? So I think one of the challenges, though, is to keep getting funding, to keep paying attention and collecting more data down the road, and that's part of what we want to do. So it's in addition to paying attention so we know whether something actually mattered or worked, we also need to keep infusing different kinds of resources, whether it's just people resources hitting the streets and trying to make some changes on a policy and like getting in new parks or safer parks or more lighting, but also so it's more funds that way in very creative ways, but also more funds in terms of data collection, because honestly, it's not a cheap thing, but it's a really important thing. So that's part of our challenge, is to try to get more funding to answer exactly that question, because I think it's critically important. And that was our kind of goal early on, is can we track this over time for the next 20, 30 years, because it's going to take a while.
I think the other thing, and I'm just going to add, we did devise a food subcommittee, and Catherine is one of the chairs of that subcommittee. We've been involved in communication and have had participants go to, for example, there was a city hearing about bringing in a supermarket into one of the communities. In the course of when we first started, we had actually lost some supermarkets, and so the fact of participating and having folks meet on a continual basis to try and impact policy, which has a bearing. And just to bring it back home to social determinants, you can try and impact in terms of advocacy, but if a store doesn't have an incentive in terms of coming into a neighborhood or into a municipality, if they have a standard where they set arbitrarily, say, 2 million as their goal to open up a new store, then you really have to do a lot more to impact that policy in low-income communities. And that's why this whole thing about social determinants, it's a very important aspect of doing public health work, but it's not as easily measurable in terms of definable, measurable outcomes when the system itself does not provide for or is set against serving low-income communities. And with that, I just wanted to, because George and I have talked about this, and we talk about this every time we go out and have people from federal agencies. 30 to 40% of our membership and our communities do not have computer access. We are the digital divide. And so when all these agencies, and I recently met with the head of the Office of Civil Rights, when all these agencies say, well, simply, this is a great thing, we're breaking down the silos, and you just go online and you can file a report and a complaint and whatnot, and that's great if you have access. But for many of these communities, they don't have access, and if they're over a certain age or, meeting a certain educational background, making a report online is going to be very, very difficult. And that's the challenge, I would say, to you, is how can you be effective with communities that you want to serve when the apparatus and the system and the mechanisms, the structures are not conducive to serving those communities. We want to work with you on finding those solutions.
We probably have time for about one more question, so I just want to honor the 1 o'clock time frame.
Yeah, go ahead.
Very thorough. When you went out initially and formed the focus groups and made your first initial contact, how did you evaluate whether you had a representative sample of the right set of partners advocating?
Well, from my perspective, that's always hard to do. You never really know. But I think that's one of the beauty of doing this type work, that it isn't an all or nothing, and that's your only chance. It's an iterative process, and you're always going back and asking, who else do we need to talk to? And even looking at, well, who did we bring to the table this time? And that's why even after those first initial focus groups, which I wasn't involved in, I'd never heard of it, taking A Word Health to heart back then. But once we did get the data and we wanted to disseminate it, we decided that we needed to take it back to community and even get more voices. And so we're always doing that. We don't stop.
Can we just hear what Tariq's question is?
You know what? If we want to, I'm going to go ahead because I want to honor that time. It is 1 o'clock.
Okay.
They will be here They're going to meet with some other people, so if you want to hold out and hang out just for a minute, Tarek. Oh, I'll stop. Okay.
Stop.
But let's
that works.
Let's all give them a hand for coming out today.
Charlene, I was going to say I still have in the back of my head always who's not here because of you. That was good, what I was going to add. That's good.